The broadcast is now starting. All attendees are in listen-only mode.
Thank you for joining us today for Improve Employee Engagement with Data Analytics. This webinar is being offered with a 1 professional development credit for SHRM CP or SCP. I'm Cara Tarantino, the Vice President of Marketing with Orthus Health, and I'm thrilled to be presenting today with our data partner, Richard Kirsch, CEO of Human Factor Analytics. Richard, to get us started, why don't you first share a little about Human Factor Analytics?
Thanks, Cara. Good afternoon, everyone. My name is Richard Kirsch with Human Factor Analytics. Our company is basically a relational database that intakes employers' medical, pharmacy, biometric data, HRA data, workers' comp data to identify risk mitigation opportunities within a population. Our company was founded from a background in wellness programming over the past 20 years and doing various research projects to validate risk mitigation opportunities. And our association with Orthus is that through Orthus and their ability to communicate in various modes, it gives the analytics a voice to be able to go to drive risk management principles to the individual basis.
Great, thank you, Richard. At Orthus Health, we focus on minimizing the life consequences and costs of chronic disease. In a nutshell, we have a scientifically proven predictive model that accurately shows individuals their risk for 6 chronic conditions and gives them a highly visual pathway to change. We demonstrate to employers the costs they can avoid when employees modify their health risks. Because our model is precise, we can offer relevant and targeted interventions through wellness, health management programs, and coaching, for example, that are personalized and easy to take action on. In addition, our model enables employers with programs already in place to measure their investment in those programs and evaluate whether they are working or not. So today, in discussing the role of data analytics in employee engagement, we want to look at engagement from different audience perspectives. We may be here today as employers, consultants, resellers, health systems, but we are also individuals and employees too. We are also consumers, patients, and caregivers. How we see the data, learn from and act upon it depends on many factors, and our perspective from the different roles we play is critical. I'm going to start out by what I hope you will find an interesting data dump. Let's get the blood flowing. Let's get our minds to question what you're currently doing to engage employees and enable you to see health and engagement in a new way. Then Richard's going to do a deep dive into claims analysis, predictive modeling, and stretch you to look beyond what may be hidden, but what you are surely already paying for. And if we have time at the end, we will challenge Richard with some tough questions that we have experienced in the past with employers. So when we look at improving engagement, it is certainly a CEO imperative, but it's all of ours collectively. When we look at our culture, we're looking at how things are done. And when we look at engagement, we're really looking at how employees feel about how things are done. The challenges we face today, competition for millennials, we need technological and special skills from employees as we digitize our businesses. Our brands today are very open and transparent. People can see if your company is a place that they want to work for. Social media has really opened up that transparency for us in a lot of good ways and in a lot of not so good ways too. So engagement and health are inextricably linked. When we look at the relationship between the two, there are several important impacts to consider. One is the impact on productivity. How does it affect turnover, retention, absenteeism, even safety? What's the financial impact? When we look at our overweight and obese population, and those with chronic health conditions, they miss a lot more work every year. And the health impact is highly engaged individuals have lower chronic health problems. And of course, that's the chicken or the egg scenario with that impact. We're also experiencing a power shift in the workforce. Today, employees are more like free agents. The power is shifting from the employer to the employee in pretty much the same way it's shifting from the healthcare provider to the consumer and the patient. So if we're going to build what we want to call irresistible organizations, the place where people want to be, the place where people want to not just stay, but grow and feel purpose and contribution, we need to look at these different perspectives. So the data is really important. The data is going to tell us stories. It's going to enable us to share ideas. The data can motivate us. It can record history, track ROI, which I know is something that's front of mind for all of us. So what data, when used effectively, encourages your employees to rise up and set their own bar? As we look at these things, what can you pull from what we're talking about today that will help employees assume greater accountability, not only for their health, but maybe for the relationships they have with their colleagues, with clients, and with others? If you haven't seen the movie Hidden Figures, I highly recommend it. It is the story of three brilliant African American women who are working at NASA in the 60s and on a space task group to get the first American into outer space and land on the moon. So Katherine Goebel Johnson is one of, actually she's the only female Black American in a group of engineers and other mathematicians who is working on calculations. And her colleague hands her some work to do, and many of the pages are blacked out for information that's classified that she can't see. So she works on it. Her boss calls her into the office, and he says, "How did you arrive at these calculations when most of it is blacked out?" And her response was, "I cannot work on what I cannot see." And he asked, "How did you arrive at these figures then?" She said, "I held the paper up to the light." Well, we would never dream of hiring an employee and blacking out information that we need them to know, but they shouldn't know, and expect certain results. But yet we do it every day when it comes to health. We institute programs and we think that they're good enough. They don't need to be precise. We can't afford more, and we expect certain results. We even have an employer that we've worked with for a number of years. They're very dedicated to making a difference in their overweight and obese population. They incentivize people all the time, but one of their incentives are gift cards to Applebee's and Chili's. Oh, by the way, those are the restaurants that you buy one 2,000 calorie meal and you get the second for free. So even our best intentions, we are unintentionally putting the black marks on the paper that people can't see. So I highly recommend you see this movie. There's so much to learn from. And if you've already watch it again and see what you can apply to what we do in our day-to-day lives with engagement and with health. So the numbers should be transparent. And this really has nothing to do with privacy or security. It should be, for us as individuals, we should know what our data means. It really takes into account health literacy and data literacy. The reports that we provide to employees should make sense. They should want to read them. They should not be hesitant to ask questions because the data is clear and it means something. So just to give you some interesting statistics, hopefully open up your minds a little bit more, is our reality with health today is really in the data. So if we look at what the CDC tells us, by age 65, 50% of all Americans will have either diabetes or prediabetes. So there's a lot of work to do. And I really believe that from our different perspectives, from our employer perspective, employee perspective, vendor, partner, caregiver, we need that collective perspective in order to make a difference. We have a lot going against us. Sometimes people do things that are irrational, really, surprise, surprise, and even counter to their best interests. Why? Because it sounds like a good idea at the time. Sometimes we just want to do things because we can. Surveys show a number of things that drive behavior. Taste is number one. Food industry is amazing. It's amazing what they can do with chemistry today and the flavors that just attack our taste buds. We eat it up literally and we love it. So the second thing we look at is price. And the third thing we tend to look at is healthfulness. And healthy is a confusing concept. Those of us who work in healthcare on a day-to-day basis struggle with it in how to communicate and understand it ourselves. Imagine employees who may not have any interest in it whatsoever, only because they have to take a look at it, or just don't understand it because it's too confusing, or it changes all the time. Some other interesting data I'd like to share with you is today's worker is 13 pounds heavier than the average worker of 10 years ago. So if you look at the diagram on the right, you see we kind of have a triple threat. The workforce is aging, obesity is a problem, and with that, we have poor muscle strength. I don't really hear a lot of people talking about that as much in wellness. They might talk about it when you go to the gym, but poor muscle strength really impacts our risk for chronic disease. Our shoulder strength is weaker, our knee strength is weaker, and low muscular strength is a risk factor for diabetes, cardiovascular disease, metabolic syndrome. And then some of the issues we experience with health, such as back issues, are actually shoulder issues. And as you can see, the cost for an employee with a weak strength to BMI ratio is significantly more than somebody with a stronger ratio. So I'd like you to meet my buddy Joe. We all know Joe. We work with Joe. We're friends with Joe. This is some interesting statistics that, in fact, just came out this week. Healthy but obese is costing us. So an obese 50-year-old who has normal blood pressure and normal cholesterol will cost society more than $36,000. If you look at the footnote at the bottom, that's a range. 50-year-olds are the ones who are going to cost us the most. So Joe's struggle is affecting all of us, raising all of our health insurance premiums. And as you can see, Joe's not looking too happy. I'm going to talk about Joe a little bit more, but this is a great slide, and I wanted to share it with you to keep it in perspective as we look at Joe's experience a little further. There are 8 modifiable habits. Only 8. There's probably a lot more. These you know very well: exercise, drinking too much alcohol, stress, lack of preventive screening, sleep, that drive 14 of the conditions that account for 80% of the total cost of chronic illness. So if you're looking at that 80%, and there's only 8 modifiable habits that go into it, where do we need to direct our efforts? And they can't be shot in the dark anymore because we know that's not working. A little bit more data for you. Absenteeism and presenteeism are real costs. So if you look at lost productivity costs, they're significantly higher than medical and pharmacy costs. Obesity-related absenteeism, the CDC has even put a price tag on it. And this is just one example from Dow Chemical from several years back. They estimated that the costs due to presenteeism are actually triple what they're paying for healthcare. It's really something. Some other figures for you to look at is when we look at our employee population, we have those who are healthy. They may not move. We have those with chronic diseases that we need to look at managing. But we have a whole group in between that I like to call in the pre-zone. They're in the pre-conditioned state. We're hearing more and more about pre-diabetes, pre-hypertension, but the costs of preventing or avoiding people from moving to higher risk categories is significant. So you look at somebody with pre-diabetes. So if you have a population of 100 employees, statistics say that without effective interventions, 10 to 15% of those employees will become diabetic within 2 to 5 years. So those are costs you might as well budget for right now, because they're moving from $4,300 a year to $13,700 a year. And that $13,700 doesn't even take into account other conditions, other issues, pharmacy costs, caregiving costs, etc. So I am excited for having Richard here today, because he's going to show you things that you already have in the data that you're not seeing. And this is a really important place to look at the data more carefully to get people engaged in making a difference here. So what's going on today with wellness? I'm sure most of you already have a wellness program. You may be happy with it. You may be happy with parts. You may not be happy with it at all. But wellness is changing, and smart devices are definitely reinventing corporate wellness today. So this article I found interesting. It was from Nokia, so you know that they're in the business of selling devices, but they really had some great insights to share. They feel that smart devices can incentivize people. People walk the extra mile when they can see the numbers. They have algorithm-based coaching, which is pretty cool. Smart devices tend to build communities. It gives people the opportunity to share goals, get a different type of support, promotes healthy competition. There's even more effective risk mitigation because they're getting real-time reporting and feedback. So these statistics were interesting because everybody wants to know what the ROI on wellness is. And the CDC says that for every dollar invested over a 2 to 5 year period, that you can get $3 to $6 back. Well, when we look at our challenge in hiring millennials, how many of those millennials are going to be with you in 5 years? So there's a lot that goes into this equation. But data from devices does tell a personal story. It helps people walk more. There's other things as such as if people have a scale, they're more apt to weigh themselves daily and hence lose weight, helps manage chronic conditions. It's amazing what you can do with a smartphone with diabetes, managing asthma and hypertension. If people lose weight, they lower their blood pressure. So we know these things are working. We have health management programs at Orthus Health. We have coaching programs. Some of them are short term. We put people on a 6-week weight loss program with the goal of losing 5 pounds, and many people lose significantly more weight. We like to take them off the program after 6 weeks only because we have found that starting and stopping a program within a longer term initiative is very effective. And because of that, we've extended our programs to offer what we're calling in-a-box programs. So what we're doing is we're offering all the tools that people need, so the coaches don't need to spend a lot of time talking to members about where to find a scale to weigh themselves, because we're going to provide it for them. We're going to provide the tools, the tape measure, everything they need, and offer it for a longer period of time. Same thing with managing hypertension, and the same thing with looking at prediabetes and diabetes. So we can't get away from devices and technology, and I believe the growth of devices and technology is going to play even more of an instrumental part in healthcare and health prevention and wellness. I'd also like to give a shout out to those employers in low tech or non-tech environments, laborers, miners, because we definitely need to address and engage them as well in health improvement, but we're doing it a little differently. We may do manual health risk assessments or verbal assessments. There might be a little more paper involved, but it can be done. And a lot of times it takes a little more planning. So I wanted to share with you, talk about incentives and how you feel about those. How you frame your incentive influences behavior. Very interesting study. This was a 13-week challenge with around 1,300 obese individuals. The goal was to reach 7,000 steps a day. Group 1 got $1.40 a day if they hit the goal. Group 2 was in a lottery. Group 3, they got the $42 up front, and if they did not hit the goal, the $1.40 was taken away. And Group 4 was the control group. If you think for a moment where the success lies, it was in group number 3. They had skin in the game. In other words, they did not want their money taken away from them once they had it. And the results were they increased their success rate in the day they hit their goal by 50% more. Just something to think about. So when you look at your plan for wellness, for health engagement, are you looking at disease avoidance and injury prevention? Do you combine disease prevention with safety? What are the assessments you're using? What's your expectation in the data from those? And what's the support that you're providing? So getting back to Joe needs information to be accountable for his own health. We asked Joe to take the Know Your Number Disease Risk Tracker, which is an outcomes-based questionnaire. It includes biometrics. And we were able to provide Joe with certain data. And the data is quite fascinating. It's an evidence-based solution. And Joe had a risk of developing type 2 diabetes. We were able to show him the data as a 45-year-old male, not just in relation to every American, but we gave him a peer group perspective on his risk for developing chronic disease. And then we were also able to show him his modifiable risk, what was in his control. My favorite part of this whole report is it gives Joe a pathway to change. And everybody needs a personalized action plan. Joe, as a smoker, his risk factor with smoking contributes to his risk for developing stroke, diabetes, congestive heart failure. And his risk is weighted. It's weighted appropriately and proportionately. It's not statistically driven, it's scientifically driven. So his risk for disease will never be understated or overstated. So this is a summary of the report. This is what Joe received. Just a one-page report, but with that, he got a more detailed report outlining what each of these sections mean. As I mentioned, health literacy is very important. And he also receives a personalized take action report. So now that he has the data, what's he going to do with it? And the whole goal is for the employer to say, yeah, now that you have the take action, we have the programs that we know will be effective for your risk. So what do you as an employer get? Well, you need to see aggregately what the contribution of those risk factors are to the avoidable disease cases. And the other thing that, of course, is going to interest you is what is the cost of the avoidable disease burden. So when you're looking 5 years down the road and you know that if Joe and his buddies, colleagues make these changes, this is what you're going to save. These two reports, the individual report and a summary of the aggregate report, I have included in the handouts in your file. So you'll be able to take a deeper look at both of these. But what's really important for engagement is Joe's looking better. He was able to take action on his data. Is we need to recognize that change is hard. These questions are real questions that people have. Can I do it? They may be anxious. Can I make time for myself? What's really important to me? They may hate to exercise. They may hate everything about this. but there may be other lifestyle factors. There may be other things in their lives that are more important. How long will it take? The beauty of all of this is we know that small changes lead to big results, and small changes lead to sustainable results. So before we get to Richard, I just wanted to share give you some ideas of how you can support employees. As we mentioned, smartphones are our reality today, but they offer real-time communications. You can talk to a health coach telephonically, you can text, you can chat. We also offer these Spanish health coaching, and you can text in Spanish. You can keep track of anything you want to keep track of. And what about teamwork? We work with a partner who offers these very engaging walking challenges. They're available online on the smartphone, but they're focused on real-world activity. They're totally interactive, and they're very team-based. The other thing that has come up today more and more is movement is as important as exercise. So we like to focus in on sedentary disruption in addition to exercise. We want to get people moving every day. We want to give them games and activities. We want to send them notifications so that they can take action. And we want to use this to incentivize employees. Unlike a gift card that doesn't make sense, this is a true incentive because you want to get people moving and you want them to feel good. And the other thing is we have to communicate all this and we have to remind people. So speaking of which, do you send out communications to people? We like to provide weekly health tips. We like to make them short and sweet. We like to private label them and encourage people to use them via all means of communication. I haven't heard of anyone handing out a health tip before a weekly meeting or a daily meeting, but there's nothing to stop us. So effectively using the data is a people strategy. If we have relevant data, we can personalize wellness and other initiatives. It encourages and inspires engagement. And now, as we lead into what Richard is going to talk about, it can significantly reduce risk, which is what we need in order to lower our costs. So Richard, I'm going to hand this over to you now so we can do a deeper dive into the claims part.
Okay, great. Thanks, Kara. What I'm going to try to do pretty quick is explain the value of data, the meaningful use of data, and actually some pre and post outcomes that validated risk management or risk mitigation within a population. And so one of our philosophies is why use data if you can't put it into action, if you can't make it meaningful, if the data does not allow you to mitigate the risk that you're looking at. Next slide. So, for example, in December of 2016, the Journal of the American Medical Association came out with a meta-analysis that looked at healthcare spend over the past 17 years from 1996 to 2013. And this was really interesting because the conclusion of the study was that basically healthcare expenditure was being driven by 7 conditions. These conditions were diabetes, hypertension, hyperlipidemia, low back and neck pain, depressive disorders, other neurological disorders, and falls. And it even got into some subtleties such as diabetes was the most expensive of the 7 conditions. And 58% of the cost of treating diabetes was related to medications, diabetes medications. But if you look at the interaction of all of these conditions, hypertension, hyperlipidemia, all of these conditions are kind of building blocks of metabolic syndrome. And so what we're finding out is these individual risk factors like hypertension, hyperlipidemia, elevated glucose, these conditions are very powerful as standalone risk factors, but when they start pairing together and start combining and creating comorbidities. So if an individual has hypertension, hyperlipidemia, or hypercholesteremia, hyperlipidemia, then all of a sudden expenditures goes up and risk goes up. So we look at all of these risk factors and we say, okay, we now know what's driving cost. So what are we going to do about it? And so you can go through and you say, okay, I've got diabetes, hypertension, hyperlipidemia, low back and neck pain. What are some things that we can effectively do to reduce the cost or risk associated with these various conditions? Next slide. Okay, so if we're able to bring in an employer's medical data, pharmacy data, and if they have biometric data or health risk appraisal data or even injury data, that gives us a bigger picture to work from and to be able to say, okay, what do we think is driving cost within this population, and what is our game plan that we can empirically prove that we've actually reduced risk of a population? So you can see on this slide, we've got the concept of predictive to prescriptive, okay? So we know that tools like health risk appraisals, especially tools like the Know Your Numbers tool, are extremely accurate at predicting whether someone is going to develop a chronic disease, develop heart disease, develop diabetes, hypertension. And so how do we take the power of something that is predictive and actually turn it into a prescriptive-based wellness program? Next slide. Okay, this is, if you see this giant iceberg and you see the top of the iceberg and it says typical superficial population health management. So, you know, the vast majority of wellness programs say, okay, we're going to implement a health risk appraisal. We're going to ask questions about lifestyle. Do you exercise? How do you eat? Do you have family medical history of particular chronic illnesses? How do you handle stress? Even questions about occupational health and safety. We'll implement on-site biometrics. We'll apply health coaching, which can take multiple forms. We'll apply an incentive program in its various forms. All right, but in this generalized framework of wellness, I'm really not taking into consideration what the medical claims are telling me or what the pharmacy claims are telling me. And if I did dive into that part of the data, I would be very surprised. I would not be surprised, but maybe you would. So when we look at a population, the vast majority of populations that we've done analysis over the past 5 years, we find that on average, 50% of the population has some form of chronic disease. And it is this population that has chronic disease that is driving 80% or greater of the overall medical expenditures. So we know the culprits of this are just what the JAMA article said: hypertension, hyperlipidemia, diabetes, other neurological disorders, low back and neck pain. So if we're going to effectively reach for the Holy Grail, which would be, can we reduce risk and reduce cost, we've got to be aware of these other risks. So some example solutions to be able to go after these risks would be able to, through the data, be able to identify unique individuals that are non-compliant to evidence-based guidelines. And I refer to evidence-based guidelines as different types of clearinghouses have established rules that have said that if I'm a person with diabetes, I should consider being on an ACE inhibitor type of antihypertension medication to protect my kidneys. I should consider to be on a statin drug to protect macrovascular, big vessels, to prevent heart disease. or heart attacks. We can utilize the Know Your Numbers health risk appraisal as a predictor to say, all right, we think that these individuals are at great risk of these chronic illnesses. Well, we can validate that with real claims data. We can individually message instructions for personal clinical to-dos to individuals. Because I would pretty much take a bet if you would walk outside your office right now and just randomly pick 10 people. It doesn't matter what their gender is or what their age is, and say, what should you be doing right now based on your age and gender as a preventative screening? Is it a colonoscopy? Is it a mammogram? Is it a cervical cancer screen? Is it being screened for abdominal aortic aneurysms? The vast majority of those people, I would say maybe 2 out of 10 can tell you what they're supposed to be doing. So imagine a program that could be very, very individualized, very prescriptive, and a program that has the ability to capture that data on a post basis and validate that these clinical to-dos were done. Things such as increasing medication compliance, increasing compliance to age, gender preventative screenings, then monitor claims data to validate findings associated with preventative screenings. For example, we had a large governmental group that they had approximately 10,000 people that were compliant with a colonoscopy, but there was 32,000 people that were eligible. That means they were supposed to have had their colonoscopy, but only 10,000 did. And so some of the upper management was questioning, what is the true value of preventative screenings or evidence-based medicine? So we said, we'll give you this answer. So of the 10,000 people that had a colonoscopy, 2,100 people had a polyp removed, a polyp biopsy, or a diagnosis of cancer. That was a 21% hit rate of the people that participated. That's extremely high value. And with this type of strategy, we want to make the primary care physician kind of the gatekeeper, kind of the major intellectual property. So we've interviewed several primary care physicians, and we asked about evidence-based guidelines and compliance. And they said, yes, we totally believe in this, but our problem is getting the individual to come back into our office to see us or to ever see us. So we think that if we're able to give individualized clinical to-dos, we're going to optimize our chances at being successful at reducing risk. And we can do other things such as monitoring ER visits. Which one of the ER visits are avoidable ER visits? In other words, did somebody go into the ER with acute rhinitis, a stopped-up nose? Did they go in with a headache? Those are things that are totally preventable and that can be treated by the primary care physician or at-home treatment. We take it a step further to identify value-based medication, because if we're going to do strategies that are going to increase compliance to medication, wouldn't it be smart to make sure that the proper kinds of medications, the highest value medications, are being prescribed? Then we can go into root cause diagnosis and monitor them. For example, low back pain. Low back pain is usually the precursor to some of your biggest spend in your musculoskeletal diagnostic area. So if we look at someone that has a diagnosis of low back pain, if they have any type of nuclear imaging, they're going to be 8 to 9 times more expensive than their counterparts, because they didn't navigate through all of the potential cures and fixes of their low back pain, like physical therapy, strength and conditioning programs. Next slide, please. So why not stop the threat? Because we know what the threat is. The threat is going to be chronic disease, So we can intervene with the people that have chronic disease, and we could intervene with the people who have not migrated to a diagnosis of chronic disease, and hopefully keep them stable and keep them from developing a chronic illness and from developing comorbidities. Because we know as that domino effect happens, there's going to be a direct relationship to excess spending and excess risk. So through the data, we're able to identify folks that have these different risk factors. Then we're able to suggest interventions, and then on a pre-post basis, follow the data and see if we actually close those gaps in care and reduce risk. Next slide. So this is an example stratification of a population. And it's really funny because when you go to an employer and you explain things like, you know, chronic disease is growing at an epidemic rate. We know that diabetes now is considered a pandemic. It's crossed international borders. It's worldwide as a global threat. Most employers will say, you know, I think I read something like that in USA Today. But when you actually pull an employer-specific data and show them what is going on within your particular population, it really opens some eyes. So, for example, if you did a risk stratification of a population and broke them into 5 groups, the first group are people that spent less than $1,500 and they have no chronic disease. Group 2, they spent greater than $1,500 with no chronic disease. Group 3 has chronic disease with no comorbidities. Group 4, chronic disease comorbidities with comorbidities. Group 5 is chronic disease comorbidities and disease-specific complications. Now look at the bottom of this slide, and it shows the mean expenditure for each one of those groups. As I migrate to different risk groups, that group 5 has a mean or an average expenditure of $17,000 a person. Group 4 has an average expenditure of $8,700 a person. Group 3, $4,800 a person. That means that group 3, 4, and 5 are making up greater than 80% of my total expenditure for my population. Isn't that pretty good evidence that chronic disease is driving the vast majority of costs and expenditures? And then when you think back of the JAMA, the Journal of the American Medical Association research I showed you, that again gives more validation to what we're saying here. Next slide, please. A lot of employers are setting on a lot of data, but are they making meaningful use of the data? I mean, even let's take to the most basic form of data, biometric data. We had a group that we were working with that was a large truck line, and they wanted to know what were the characteristics of the new hires, what were the health characteristics of new hires that they were hiring. And this trucking industry had a 90% turnover rate, which is not unusual for transportation industry. What we discovered was when we looked at the medical claims data, there was no diagnosis of metabolic syndrome, which the metabolic syndrome diagnosis says if I'm diagnosed with that, I'm doubling my chances of developing heart disease or cardiovascular disease. So there was no diagnosis, and we said, you know, that doesn't make sense. And then we took the truck line, they had biometric data, and we were able to identify people with metabolic syndrome just by combining their biometric data and setting that characteristic up. We're able to look really quick and see medication compliance for those individuals with chronic disease. And we even do experimentation to say, is medication compliance, is that really that important? So we'll segregate, for example, unique individuals that have a diagnosis of diabetes that are currently taking an ACE inhibitor to protect kidneys and a statin drug to protect big vessels the heart, and we'll compare the expenditures for the compliant versus non-compliant. With that particular example on diabetes medication, we saw there was a $2,500 increase in the individuals that were non-compliant with those evidence-based rules. We also go in and we can see that as patterns of comorbidities, and a comorbidity is the existence of more than one chronic disease. So the pairing of chronic diseases like hypertension, hyperlipidemia, diabetes. As we see those comorbidities building, we see cost building, and we see the complications of treating that disease increasing. We're able to see preventative screenings, who's compliant, who's not compliant with that, and we're able to see the early discoveries that that age gender preventative screenings do. So if we see someone that has had a colonoscopy and we see that a polyp was removed, then we have a high probability that we have avoided a diagnosis of a stage 2 cancer or stage 3 cancer. We look at musculoskeletal, because musculoskeletal diagnostic category is one of your top 3 most expensive categories. So we want to find out what's going on here. Is it primarily low back? Is it back issues? Most of the time it is. Then we ask the next question, could the musculoskeletal issues be potentially work related? Is there some things that could be put in place on the workplace, like ergonomic fixes, that could potentially reduce risk? And then one of the most interesting categories is ill-defined symptoms and conditions. This is a catch-all diagnostic category where an individual has not had a specific diagnosis, but they have an ill-defined condition like a stomach ache. But if we keep drilling down further, that stomach ache may be related to esophageal reflux. Or if we identify someone that has a neuropathy and it's coded as an ill-defined condition, it's highly likely that person is probably undiagnosed person with diabetes. Next slide. So evidence-based guidelines are very interesting in that we have done a lot of research to show that if a person is compliant with these, we see reductions in risk and reductions in expenditures. And so the slide that you see here are the major diagnostic categories that your medical expenditures are ranged into. And so you can see in this particular group, diseases of the musculoskeletal system and connective tissue was about $1.6 million. And then the second most expensive was V codes. And a lot of times we like to see the V code expenditures go up because that's associated with a lot of preventative things, a lot of office visits, people going to the doctor. And then we look at diseases of the circulatory system. We understand that a lot of that is being driven by conditions such as diabetes, hypertension, and elevated lipids. So it's like a big puzzle you're trying to work, and you're trying to say, where can I go in and interrupt risk and reduce risk within a population? Next slide. So musculoskeletal disorders are one of the top conditions, and we know that could be related to occupational, the work site. It could be related to lifestyle factors. We've done a lot of research to show the connection of body mass index with a higher propensity of low back issues, even shoulder and knee issues related to elevated weight. And a real interesting research that we looked at is we had another trucking company that we looked at their new hires, and the new hires spent $1 million in medical expenditures the first year. The medical expenditures, 70% of the medical expenditures were related to musculoskeletal disorders. This truck line had a pre-employment physical ability test in place to equate the essential functions of the job in the pre-employment phase of hiring, they would make the applicant take a pre-employment physical ability test. The theory behind this is if they have the essential functions to do the job, physical essential functions, that reduces the propensity for injury. Well, we found out that the pre-employment test was not effectively identifying people that actually should have not been doing the job. They were spending $500,000 a year on this test, and from the data we revealed, they changed the criteria of the test. Next slide. This is the one this is a look at the data that really makes employers lean on their desk, is when you're able to show them how many unique individuals within their population have a diagnosis of a chronic disease. So for this particular group, 242 people had hypertension, 172 had hyperlipidemia, 113 had heart disease, and 90 had diabetes. So again, let's go back, think about the JAMA article, that 17-year study that showed what were the conditions driving cost. Well, this is a mirror image of that. It's like they predicted what was happening within the employer population. So if we can come into these conditions and we can manage with NCEP guidelines, JNC8 guidelines for the management of hypertension, NCEP for the management of blood lipids, cholesterol, triglycerides, metabolic syndrome, and we can direct the individuals to their primary care physician, and we can look at the medications that are being used for treatment and make sure those are high value. And then at the end of the day, capture the outcomes from the primary care physician visit. We can prove that we've actually reduced risk and potentially stopped a person from tipping into a higher level of risk category. Next slide. So how do we attack some of these things that we're talking about? We can risk stratify the population through claims analytics and know your number to create an enhanced predictive model. We can empower health coaches with evidence-based rules. And so we know exactly what a person should be doing to comply with these evidence-based rules. And the health coach will also be talking to the individual about therapeutic lifestyle change, such as exercise, weight management, proper nutrition, stress management, because we know these things are very powerful at determining what's going to happen to a person in the future. We have the ability to push out electronic prescriptive messaging to the individuals, and it's an individual story. It's not a generalized story. It is a story that has been authored to fit that person's particular gaps in care and their risk deficiencies. And we can help the employer architect an incentive program to drive higher participation rates in these types of strategies. And we oftentimes think that a human being will do anything to reduce their own risk, but that's not the case. As Kara showed at the earlier part of her presentation, you know, we eat too much, we drink too much, some people smoke, and a lot of people know that that's bad for you. So let's give an incentive to overcome some of our bad habits. Next slide. This is an example of how we can do pushes to individuals with their unique evidence-based guideline. Next slide. So this was the decision tree. So we had, push a message to someone and say, ask if scheduled metformin was taken. If yes, find out how do they feel. If not, try to find out the reason that they don't feel good or they do feel good. And I use metformin as an example because metformin is a high-value diabetes treatment medication that has been shown to reduce a person with diabetes risk at renal failure and cardiovascular disease. Next slide. So we pull all of the data in to tell the story. Everything from medical pharmacy data, biometric data, the know your numbers data from the health risk appraisal, the demographic data of age, gender, disease groups, and then we set up predictive models. Next slide. We currently are utilizing things like machine learning and artificial intelligence to be able to assign individual risk scores that predict the individual's expenditure and risk in currently and in the future. Some of the models that we have developed can account for up to 80% of variance, meaning that only 20% is going to be random. And so with the use of these technologies, we can really maximize the benefits of utilizing data to guide our risk management strategies. Next slide. And again, the data will always point to gaps in care. The data will tell us what our strategy what we need to do, because we'll generate enough empirical evidence to validate our assumptions that this is driving cost, or that if we mitigate this risk, we're going to reduce risk or we're going to reduce cost in the long term. This was an example on colonoscopies and the value of the colonoscopy. If you see over to the right, we're able to monitor the number of cancer diagnoses identified after colon cancer screening, and even the number of polyps removed and polyps biopsied. And we do that for other preventative screenings. Next slide. Okay, this again is reiterating the predictive modeling. And we were able to answer questions with analytics that a lot of employers were looking for a resource for this. So for example, if medication compliance is important, wouldn't it be important to understand what is the cost of non-compliance? So if 70% of the employees were compliant with hypertension medications, what is the cost of non-compliance? That's pretty motivational when you're able to calculate that and know that if we increase compliance, we can actually save money in the long run and reduce risk. The same thing with musculoskeletal claims. We can develop relationships to say what are actually driving these diagnostic categories and how can we intervene. Next slide. Okay, Kara, I think that I've run a little bit over. Would you like to allow some time for questions?
Yeah, I want us to end right on time, but I do have an important question I think everybody might be interested in, and one that has come up time and again with employers. Can you briefly give an example of hidden risk that analytics has revealed to an employer, and was this risk able to be mitigated with a solution?
That's a very good question. We've gone in and done an analysis of the outcomes associated with the results-based wellness program, where the employer had established criteria that the employees, if they achieved 3 out of 5 of the criteria, their premium differentials, they were given a reduction in their premium of about 20%. And so the CEO of the company asked us to evaluate how much money that the results-based wellness program had saved. That's the question. He said, how much money did I save? Not, did I save money? We went in and discovered that the people that got greater than 3 of the 5 criteria actually had expenditures of $2,500 greater than non-participants. And so what we discovered is the majority of the people that were passing the criteria, here's an example criteria: blood pressure less than 140/90 or be on medication, cholesterol less than 220 or be on medication. What we found out is that 72% of the people that had 4 out of 5 or greater criteria that they passed had multiple comorbidities and multiple diagnoses. These individuals were already medicated, So by the very fact that they were medicated, they passed the criteria. So we went down into the data and found out that in this particular population, a lot of their cost was being driven by non-compliance to evidence-based rules for diabetes. Less than 20% were compliant. So the next year they put criteria for people with diabetes, people without diabetes, people with no chronic disease. So it was a fair playing field. After 1 year, compliance to evidence-based rules for diabetes increased by 39%. And as a bonus, everyone that had a diagnosis of diabetes, all of their biometric levels improved as a byproduct of compliance to those rules. But there's endless examples of this, and I know we're limited with time right now.
Great. Thank you so much, Richard. So in wrapping things up, we know that health and engagement pretty much takes a village. We have what employers want and need, and we have what employees want and need. And it's really a matter of balancing them out. And I'd just like to leave you with one final note. At the end of the day, we're looking at individuals and their journeys. And we do a lot of success stories at Orthus Health, and we uncover a lot of similarities between these stories. And this just shows you a snapshot of some of the people and their journeys. And most people start out with telling you what they didn't want to do, and they have an aha moment. They get support, they track, their journeys are ongoing. But at the end of the day, we just don't want to forget that we are these individuals, and this is an ongoing effort for all of us. So I thank you for your time today. We'll be following up with you, making sure you have your certificate of completions for your personal development, professional development credit. Here is our contact information. We are more than happy to connect with you following today and answer your questions and hopefully have further discussions with you. So thank you all so much for your time and attendance.